TRI Research Conference this Tuesday. I want to thank you all for coming. I'm sure a few more people will trickle in as we start. Today we're very, very fortunate. We have two visiting professors who are world experts in their respective fields. Let me first describe. Dr. Bonow is going to discuss the pros of the cons of the utility of viability testing prior to surgical revascularization, and then Dr. Gersh will discuss the pro side. Let me first introduce Dr. Bonow. He completed medical school and internal medicine training at UPenn. He then trained in cardiology at the NIH, ended up staying there for nearly 20 years, and then moved to Northwestern as the chief of cardiology there. During that time, he served as the president of the AHA, and now at Northwestern, he's the Goldberg Distinguished Professor, as well as the Vice Chair of the Medical Department and the Director of the Center for Cardiovascular Innovation. So welcome. We also have Dr. Gersh. Dr. Gersh trained in medical school and internal medicine in Cape Town, South Africa. He then went to England, where he studied at Oxford as a Rhodes Scholar and completed his cardiovascular training there in London. He moved on to the Mayo Clinic and did a few years as the chair of cardiology at Georgetown School of Medicine. He then went back to Mayo and is currently a professor there, world expert in HOCM, as well as atrial fibrillation and a leader in cardiovascular clinical trials around the world. And today he'll be discussing the pro side of this debate. So please welcome you up, and we'll start with Dr. Bonow.
Thank you, Matt. Can you hear me in the back? Is the mic on? It's okay? Thanks. Great pleasure to be here today, to visit a lot of friends at the DCRI, and obviously to interact with Dr. Gersh. We go back quite a ways. And I'll be taking the con side of this argument, myocardial viability testing before surgical revascularization. I met with the fellows early this morning. We talked about careers, things to do and things not to do. Something you never do is to debate Dr. Gersh. Never, ever agree to do this. And so why did I agree to do this? I mean, he's charming, he's intelligent, he's got this nice, folksy South African accent. He's full of data, got a lot of barbs, and he's also an insider because he and I chaired this session at the ACC meeting a few weeks ago. He knows everything I'm going to say. He's probably been on the website and downloaded all my slides. In fact, Anika asked me to send the slides in early. She's had my slides, and Bernard just loaded his earlier because he probably didn't trust me. He probably thought I'd try to get inside information too. So we actually agree on a lot of this, and so this debate is somewhat, I think, a little bit artificial. That's what he told me. I don't trust him. I think he's going to come up with some good stuff here at the end. So let me give you the strong case I can for con. Assessment of viability is often used to predict improvement in LV function after CABG. Thus, we select patients sometimes for CABG based upon this information. We can use SPECT, dobutamine, PET, dobutamine echo, PET, or cardiac MRI. Now, I've worked in all four of those areas. I've published it. A lot of my mid-career CV is loaded with papers about myocardial viability testing using all four of those modalities. It does work to identify what's alive and what's not alive. But this also has led to numerous studies suggesting that we're not only identifying what's viable, we're also identifying who's going to live and die, who's going to survive better after CABG. In fact, there's a meta-analysis out there from Kevin Allman. It's now 10 years old. 24 studies, 3,000 patients, mean ejection fraction 33%, all have coronary disease. They get a viability test in these various studies. It's either PET, dobutamine echo, or SPECT. And then they subdivide the patients into those who have viable myocardium on the left versus non-viable myocardium on the right. And the data speak for themselves. If you have viable myocardium, your outcome is much better if you're revascularized with a mortality rate of 3.2% per year versus a mortality rate of 16% per year if you have viable myocardium treated medically. Now, this is a meta-analysis that I'm sure Kerry Lee would tell you should never have been done because these studies are all retrospective. They were not designed prospectively. They use different testing methods. They use different thresholds for what's viable or not. Different criteria, And that also may have selected which patients were sent for revascularization or not. And so this is significant. Now, a surgeon comes along, like Bob Jones, and he says, now wait a minute, look at this non-viable group over here on the right. They're not hurt by revascularization. Their outcome is the same. The group on the left does better with revascularization. Here's your answer. Let's revascularize everybody. From a surgical point of view, I can't argue that that would be a wrong interpretation of these data. But I'm glad that Chris O'Connor is here also, because 16% annual mortality rate with medical therapy, that's very high. These are data from the 1990s, and very few patients, if any, probably very few at all, got beta blockers. This is not unique data. We have a meta-analysis from Schinkel and co-workers, very similar data on the left, a meta-analysis from Kamichi and co-workers. Some overlap with the studies quoted, but some additional studies as well. Very similar findings. Now, the limitations of these cohort studies is that, as discussed, they're retrospective. They use heterogeneous methodology. The decision for CABG could have been influenced by the results of the test. There was inadequate, in many cases, adjustment for baseline variables. And finally, these were carried out before modern aggressive medical therapy. What do we know about modern aggressive medical therapy? Beta blockers also improve function in patients with ischemic cardiomyopathy. And if beta blockers do that, they don't make the scar tissue beat better. It makes the viable tissue beat better. And we have data from SPECT, contrast CMR, and dobutamine echo. In fact, Ray Kim is a co-author on the contrast CMR paper, demonstrating that beta blockers also identify, viability also identifies patients in whom beta blockers will improve function. So that led actually to some of the equipoise surrounding the development of the STITCH trial. And as a STITCH investigator, I'm going to spend the next couple minutes talking about the STITCH, which many of you here, obviously at DCRI, know quite a lot about. The main STITCH paper, of course, came from Eric Velasquez as the lead author, but a sub-study of this, which was designed prospectively, included those patients who had viability testing. Not every patient received viability testing. It's roughly 50% of the population. We did look at the differences in patients who did and did not receive viability testing. We can talk about that later if we need to. The primary endpoint was all-cause mortality, and the viability test we used, because it was your tax dollars at work, was echocardiography and SPECT. We did not use PET and dobutamine echo. We identified the prospective criteria of what would identify patients having substantial viability versus not, but we did look at it using other cut points as well as a continuous model. But the dichotomous definition of whether patients had viable myocardium versus no viable myocardium is shown here in patients followed over the course of 5 years, looking at their mortality. And so if patients have viable myocardium, they've got indeed a better outcome than patients without viable myocardium. But in the context of a large clinical trial, there's lots of things which drive the outcomes. And as you see here, variables associated with mortality importantly included, number one, how sick were the patients? A clinical risk score, age, diabetes, renal function, other parameters were very important in driving the outcomes. Left ventricular function was also a very important determinative outcome, whether it's ejection fraction or the extent of remodeling, diastolic and systolic volumes. And myocardial viability, as you can see, was significant in a univariate analysis. But when we did a multivariable analysis, we found that this was no longer a significant predictor of outcome because all those other factors were the things really driving the outcome. We then looked at the interaction of myocardial viability, treatment assignment, intention to treat to revascularization versus medical therapy, and survival. And so we have the group without viability on the left, the group with viability on the right. No significant difference in outcome, whether treated with revascularization or surgery, and the interaction p-value, as you see, was 0.5. So there was no significant interaction. We also looked at not only intention to treat, but also treatment received, because not every patient assigned to medical therapy stayed on medical therapy, and vice versa. There were some crossovers, but even with a crossover adjustment, no significant interaction was observed. It's worth noting, though, that viability does identify a somewhat lower risk population, that there's a 38% lower mortality in the group treated medically if they have myocardial viability. So what do we know? Here's some data where we look at the ejection fractions in stitch on the right compared to those 3 meta-analyses shown previously. The patients with stitch, if anything, had worse ventricular function compared to the previous analyses. But when you look at the outcome with medical therapy, you find that the mortality rate with stitch on medical therapy was 7% per year compared to those other studies, including the Ullman meta-analysis where it was 16% per year, because we use very good evidence-based medical therapy. Over 90% of patients, about 92% of patients receive beta blockers, ACE inhibitors, statin, and aspirin, which you don't see in those earlier studies before beta blockers were commonplace. Now, would PET yield different results? A criticism has been that we used these old-fashioned methods of echo and SPECT. They're identical to the echo and SPECT methods used in those prior studies that we quoted, but we didn't use PET. Would PET yield different results? Well, the Ullman meta-analysis shows, if we look at the reduction in mortality rate as predicted by their non-invasive test, we see PET, SPECT, and echo. This is looking at the magnitude of the reduction in mortality as predicted by those tests. Clearly, PET was not behaving better than SPECT or echo. There's a very small but publishable randomized trial of PET versus SPECT, where patients are randomized to one method or the other, and then we allow care to be delivered. No difference in outcome whether patients are randomized to PET or SPECT by Siebelink and co-workers. And then we have the Part 2 trial of patients randomized to PET versus no imaging with heart failure, and then followed prospectively. And the randomization to PET-guided care did not lead to a better outcome than patients receiving standard of care. And then finally, there's this paper from Ling and co-workers at the Cleveland Clinic. This one's worth noting because this one came in on after stitch, which said that the PET identification of viable myocardium was indeed predictive. It depended upon how much myocardium was identified as being viable. And so one sees here the percent of myocardial hibernation as a function of left ventricular function, and whether patients do better with medical therapy or early revascularization, looking at the log hazard ratio. And it took about 15 to 20% of the myocardium to be identified as being dysfunctional but viable to lead to that better outcome. And so here are their survival curves, looking at the different degrees of hibernating myocardium, 5%, 10%, 15%, or 20%. It's only when you have 15 or 20% of viable tissue that you see that the curves diverge. Medical therapy or MT, early revascularization is ER. So early revascularization led to a better outcome. So here's the way I interpret this study. Early revascularization meant they had the test done and then got revascularized. They waited 92 days to start the clock. And so all of these early endpoints show no difference in the early mortality between surgery versus medical therapy because they started the clock at 92 days. So all of the post-operative deaths that occurred were not included in that analysis. Now, we could do the same thing if we wanted to with stitch. We could look at this curve right here, and let's just take away those first 3 months and start the clock at that point. We probably also might come up with different results if we actually did that. I'm not sure that's the appropriate way to tell your patients ahead of time that you may not live or die, but we'll see how you do starting at 90 days. We also looked at this as a continuum, as they had done, and here we're looking at this is something thanks to Leland Shea, who did this for us recently, looking at the extent of viability as a continuum. And we're looking at the difference in 5-year mortality, medical in red, cabbage in blue, subdividing the patients according to how much ventricular remodeling is occurring in systolic volumes of less than 84, which is our median, versus greater than 84. Still, there's no separation of the curves, even when you look at the continuous nature of the viability signal. Now, how about CMR? I will tell you, when I want a viability test these days, I tend to use CMR, thanks to the work that Ray Kim and you and I have done together, because it really gives us a great signal for CMR. Are there data looking at survival with CMR? Ray may know of other data. This is the only one I know of. It's by Gerber and co-workers, looking at a series of patients, 131 patients, mean ejection fraction 24%. So here are the group with viable myocardium, yellow and orange, demonstrating that if you have viable myocardium and have complete revascularization, you appear to have a significantly better outcome than the patients who have either medical therapy or incomplete revascularization. For completeness, we're showing the non-viable groups here as well. But these are not adjusted data. The patients who were treated medically, for obvious reasons, were sicker. They weren't sent for surgery. And so they then did a propensity analysis where they tried to adjust for this. That leaves you only with 73 patients. And when they start adjusting for the baseline differences in the population, you can see those two curves get a lot closer together, barely significant, and I'm not sure that's clinically meaningful with such a small data set. I'm not aware of any other data with CMR, but the data all, for me, starts kind of adding up together. And by the way, if you go into this paper, like so many others, when patients are treated medically, that's all you know about the patient. They don't tell you what the medical therapy actually was. What medical therapy? So are these results unique? I think the Stitch results actually play into what we already knew about this whole field. We have a paper by Samadi and co-workers at Yale University looking at patients who have a baseline ejection fraction of 24%. The gray curve are the patients in whom the ejection fraction increased after revascularization. The red curve are the patients in whom there was no increase. And so despite the fact that the function is a lot better in one group after surgery, their survival is the same. It would suggest that if we're revascularizing patients to improve outcome, it may or may not be related to whether their ventricular function improves. If we revascularize a patient completely, they've also now have less jeopardized myocardium when the next platelet plug occludes one of the coronary arteries. And it may be that we're preventing sudden deaths as opposed to preventing heart failure deaths. I don't know, that's somewhat conjectural, but these data would not show that improving ejection fraction makes a difference. And there's also a paper by Cleveland and co-workers called the HEART trial, which randomized patients with viable myocardium to revascularization versus a strategy of medical therapy, aggressive evidence-based medical therapy, and they found no difference in outcome. You'll notice this is also a small trial. It was terminated prematurely because of under-enrollment, and then Dr. Cleveland joined the Stitch team and then contributed patients to Eric's study, and Eric has joined us in the back of the room. So viability does matter. It is alive and well, but it's identifying patients in whom there's probably going to be a better outcome with evidence-based medical therapy, as well as patients in whom there might be a better outcome with revascularization. This group tends to have a better outcome, but it doesn't necessarily stratify who should be receiving one form of therapy or the other. It should not be a prerequisite for decisions regarding medical versus surgical management in patients with ischemic LV dysfunction. So that's my presentation. I'm going to turn this one over now to Bernard, and I know I'm going to be in for real trouble because you are a tough customer.
I don't know about that. It's interesting to take the same slides and see if we can come up with a different opinion. I wonder if, where do I go? Thanks, man. So Matt alluded to the fact that I went on to Oxford and after graduating in Cape Town, and the Debating Society at Oxford is a time-honored English tradition, and the Oxford School of Debate really is facts 20%, humor 10%, but 70% is eloquence and style. And that's been modified by the medical community in what I call the Cindy Grimes, David Holmes version of the debate, that facts 20%, humor 10%, flexibility 0%, and character assassination 70%. Well, the problem is I know Bob very well, and he's of impeccable character, so I'm going to have to try and see if I can twist the facts a little bit instead of a personal attack. There does remain a role for ischemia and viability testing, and I want to address both. And just begin with a few general comments about myocardial viability and prognosis in patients with LV dysfunction, because I think it is very relevant, and that is viability is not an all or none issue. I mean, there are a number of issues that related to patient selection, viability, the extent of viability, the presence of ischemia, the ejection fraction, when is it too late, the extent of remodeling, the extent of scar, and the duration of hibernation. So the real question is, how much is enough? It's not an all or none issue. It's not just viability, yes, viability, no. And we need prospective studies, and we needed this study, and we need trials. We need more studies. And this is an interesting meta-analysis that tries to get to ask the question, how much viability is enough? And in this study by Inaba, 29 studies in a meta-analysis, he looked at three techniques, PET, stress echo, and SPECT, and looked at the extent of viability that would be associated with an improvement in survival after revascularization. Again, not randomized, but it ranged from 26% of dysfunctioning myocardium needs to be viable with PET versus 39% with SPECT. Again, pointing out the difference in the techniques, but again, the fact that it's not just viability, it's how much viability. Well, you've seen, this is the Kamichi meta-analysis. Very impressive. Looks like the Ullman meta-analysis, viability present medical therapy with revascularization. But I will concede that the era of medical therapy at the time of these non-randomized studies was significantly less comprehensive than it is today. And that is a valid point. To go back to the Ling paper of 648 patients, EF 31% with PET imaging, the predictors of all-cause death were hibernating myocardium, the percent of ischemic myocardium, and the extent of scar, which predicted in the other direction. And this was the relationship which was cut off at about 12% of myocardium, identifying those patients who would benefit from early revascularization versus medical therapy. Pretty persuasive data, I think, although, again, I have to accept the point about the clock started ticking at 90 days. But nonetheless, this is a very large study, 648 patients, suggesting that there really is a role for identifying myocardial viability, hibernation, and scar. So we come to the STITCH trial, without viability, with viability, not STITCH trial, the STITCH sub-study, which Bob has shown you. And clearly, if you have viability, it identifies a better prognosis. But what was a surprise were these data, that if one looked at the benefit of surgery versus medical therapy, if anything, it appeared that the benefit of surgery was greater in those without viability. And my reaction to that, I guess, is the idea might yet prove to be another beautiful hypothesis slain by ugly facts. And the question is, has Bob been wasting his time for the last 25 years studying viability? It must be painful for you to take the side you've just done, Bob. I share the pain. I mean, I sympathize. And another way of looking at this is, if you're not confused by these data, you're just simply not thinking clearly. So what are the limitations? First of all, it is not a randomized trial. It's a sub-study from a randomized trial. And viability testing was performed at physician discretion. There are baseline differences, considerable, between patients who did and did not undergo viability testing, and that's shown in the appendix to this paper. The viability testing may have influenced certain aspects of clinical management, and it was determined in a binary fashion, although you did throw a curveball there. I didn't see your slide of the continuous variable, but at least when I made this slide, it was, at least in that paper, determined in a binary fashion. And then the question is of PET and CMR. And I think all of us who order viability testing these days rely on PET or CMR, at least at our institution. And then I think another important difference, and that is we have to distinguish between dysfunctioning viable myocardium and reversibility. And there's a subtle difference between the two. You can have viable myocardium that doesn't reverse with revascularization, and that is a completely different endpoint and methodologic approach. The other part of this sub-study from STITCH, or these sub-studies, relates to the work on ischemia. Now, viability and ischemia are distinct concepts and mechanisms. Inducible ischemia yeah, it must be viable to be ischemic, but it doesn't necessarily mean it's dysfunctional at rest. An ischemic myocardium is not necessarily, at least inducible ischemia must represent viable myocardium, but not necessarily dysfunctional myocardium at rest. Viable segments are not necessarily ischemic, and the two may be at variance with each other. So one can have viable myocardium which is ischemic and not ischemic. So in the STITCH trial, there then came this study of inducible myocardial ischemia and the outcomes of revascularization. Now, in stress testing, and the reason that I'm dealing with ischemia in the same context as viability is I think the explanation for both of these negative studies I'm going to show you is the same. This is also surprising. 64% in this study had inducible ischemia. The percent of ischemic myocardium, 18%. I might remind you that this is almost the same as the rationale for the huge multi-million-dollar ischemia trial that NHLBI is doing right now. And if you look at this study in those without ischemia and those with ischemia, there's absolutely no difference between medical therapy and bypass surgery. So are we now ready to accept that the principle of viability can be discarded? Are we also ready to accept that the principle of ischemia should be discarded on the basis of a sub-study from the STITCH trial? Because this is a pretty profound statement to make or conclusion to draw. Now, this study from Rory Hachimodrich of using cedar-cyanide data of 14,000 patients with adenosine or exercise SPECT is interesting and may help us understand some of these data. Shown here is the total amount of ischemic myocardium on this axis and the log hazard ratio. And again, we get around 12.5% or 15% of the myocardium. If more than 15% is ischemic, we see a benefit from early revascularization over medical therapy. And again, these kinds of data, what are driving the ischemia trial, and some of the data from Leslie Shaw here. But this is 14,000 patients, and similar to their prior data. But there's an interesting aspect of this study, and that is that what was the role of ischemia in patients who already had a fixed myocardial defect of more than 10% of the myocardium? In other words, what was the role of ischemia in patients that also had significant scar tissue? And in those with a greater than 10% fixed myocardial defect, the interaction with ischemia was non-existent, was non-significant. So the percent ischemic myocardium in patients with significant scar tissue fell away, 0.089. And the ischemia treatment interaction shown here, 0.001, is now 0.489 in those with a fixed defect, greater than 10% of the myocardium. And if you look at STITCH, and this is the same slide, compared to the prior studies in the meta-analysis, the STITCH patients were very sick patients. Ejection fraction 27%. And as I try and put it together and try and understand when is ischemia and viability a target for revascularization, clearly in patients with normal LV function, in this setting, the severity of ischemia and the severity of angina are the targets for revascularization. Quite understand that. What about the patient with moderate LV dysfunction? Ejection fraction 35 to 40%. In those patients shown here, I think this is an MRI. I don't know. The only paper I ever wrote about imaging was to attack the STITCH sub-study, but I think this is an MRI, and I'm told it represents an ejection fraction of 35%. But in this setting, it is hard for me to believe that ischemia and the severity of angina, and for that matter, the extent of viability, it's hard for me to believe that that viability is not a target in this setting. And then you get to the STITCH trial. Severe LV dysfunction, EF 20% or so, most of the ventricle occupied by a substantial amount of scar tissue, and even I can read this patient's had an infarct here and down here. Here It's not that the concept of ischemia or viability is dead. It's just, I think it's overpowered by the impact of scar and remodeling. And this is why I actually think that CMR is such a valuable test, because it looks at more than just viability. So I haven't disregarded the concepts of viability testing and ischemia testing based upon the results of this trial. But it has had a clinical impact. First of all, it is clear that, as Bob pointed out, that the mechanisms of improved prognosis following revascularization may be due to an increase in resting ejection fraction, secondary to recovery of hibernating viable myocardium. But there are other mechanisms. Reducing ischemia and reducing ventricular remodeling has a huge effect on sudden cardiac death. And if you go back to the original CAS trial of surgery versus medical therapy, bypass surgery versus medical therapy, the major benefit in those with LV dysfunction on prognosis was actually on sudden cardiac death, a paper that David Holmes and I published. So there are, and I accept that there are other benefits to surgery independent of an effect on hibernating myocardium. And then there is also the effect of ischemia on diastolic dysfunction and symptoms of heart failure. So I do not expect or do not propose that all the benefits of surgery are because of reversible of ischemic dysfunctioning hibernating myocardium. But I have changed my clinical practice as a result of this. I think that there are patients with LV dysfunction where it is not essential to do viability testing. If they have severe angina, if they have good distal vessels, if they have no Q waves on an electrocardiogram, if they have preserved voltage, and reasonable surgical risk in terms of comorbidities, we don't need viability testing. That patient needs bypass surgery. But there are other patients that are much more difficult. They have severe LV dysfunction. We're in the range of 25% ejection fraction, significant perioperative morbidity, mortality. When is the ventricle too large to improve? When you start to get into the 6 centimeter range, I think this is dangerous territory and you need more information. Obviously, the patient is not a good surgical candidate if incomplete revascularization is likely, and particularly the patient with severe LV dysfunction when angina is less severe. They've got class 1 to 2 angina, not 3 or 4. And here, I think we're dealing with a significant perioperative mortality, even in expert hands, and we need additional information in regard to viability and scar. So I think the clinical indications for viability testing in patients with coronary disease and severe LV dysfunction, EF less than 35, somewhere in that range. If they've not had a history of MI, I think this certainly suggests viability. Absent Q waves on the electrocardiogram, as I've said in the previous slide. Significant angina or stress-induced ischemia. Flash pulmonary edema with subsequent improvement in EF. So if you have someone with flash pulmonary edema, no hypertension, and you find that the EF is now 50% a day later, you've got to think about viable myocardium. It doesn't necessarily mean that they need to be tested, but you at least need to think about viable myocardium. And then the patient with subtotal occlusions and collaterals. So again, I would say that if the ejection fraction is in the reasonable zone, 40, 45%, you don't need viability testing. But these sorts of patients with EFs of 25 to 30%, I think there's still a role for it. So I'll conclude. Viability may predict the response to revascularization in selected patients with coronary disease and LV dysfunction. It is certainly a marker of prognosis. It's better to be alive than dead in terms of myocardial tissue. Big surprise. It may influence the response to medical therapy, as Bob did point out. And it should not be a routine determinant of the decision to revascularize. So I'll close with this case. 76-year-old female, diabetic, CHF class 3, EF 26%, moderately dilated ventricle, mild to moderate pulmonary hypertension, critical, let me just go back, severe double vessel disease, LAD and circ, impaired renal function and a history of TIA. So she's not a great surgical candidate, but she is a potential surgical candidate. and this is from Panisha Cheryan-Thitawai, who tells me that this represents a large area of decreased perfusion with relatively preserved metabolism, and even I can read this, in the apical, anterior, anteroseptal, lateral, and inferior regions. So this is a pretty impressive demonstration of viability, and this is her wall motion in EF before and after surgery. So I think we sort of agree, and we also disagree. I still think there is a role for viability testing in selected patients, but I don't believe it should be. I think we agree that it shouldn't be routine in everybody with LV dysfunction undergoing revascularization. I'll stop at that point.
Thank you to you both. And now I'd love to have a discussion. I know we have a lot of world experts in the audience, both imaging, heart failure specialists, clinicians that take care of a lot of cardiovascular disease patients. So if we could have our audience participate and start the discussion as to how you might treat these patients. Dr. Peterson. And you can speak to the room. It is fully mic'd up and everybody will hear you.
We've moved into the modern era.
Yeah.
This is great. One more success for the DCRI. So first off, thank you both for coming. It's a rare treat to have two visiting professors, but both with such remarkable substance, but also style. It's rare to see that great combination, and you guys exemplified the best of our field today. But I'll pick on a couple of Bernard's quotes to sort of tee up two questions for you. So the first quote was on the pogo part of this, which is if you're not thinking, or you're not confused by these data, you're not thinking enough. And for some of our fellows, the idea of looking deeply, as you have, into data in various fields and try to get not the easy answer, but the one that might lead us to the next question, and then the better clarification that's needed beyond that. We so often now want to classify trials as positive or negative, supportive or not, and that's it. And it's a simple answer when we realize that life and studies and care of patients is complex. So that's one for Bernard. For Bob, it'll be the other quote, which is this idea that occasionally our best ideas and hypotheses are dashed by facts. In that regard, I'd like you to perhaps reflect again for some of our younger guys and girls who are here, how it was for you to be, how much backlash did you get from your colleagues who kind of didn't want to know that their field was under attack and that this was not science, but this was an attack on things that they held true to their form and perhaps their profession. How could you be so blind to that ischemia that was up there? Why didn't your results defend what we already knew?
Well, I respond to both in a way. I mean, I think the great trials are the trials that disprove logical hypotheses. And I think of the CAST trial. I mean, the rationale for getting rid of PVCs, and this was 1985 for the fellows, PVCs were bad for you. We had a lot of epidemiologic data, did the trial, antiarrhythmic drugs are bad for you. One of the great trials. I think the other along the same lines was the PROMISE trial of milrinone. Certainly the drug improved ejection fraction, but changed our whole thinking about the approach to heart failure. In regard to the other quote, you're confused by this and you're not thinking clearly. I think when I did see the data, I was surprised. I mean, my preconceived viability is such a logical concept. And then when the ischemia sub-study came out, I remember talking to Eric, actually, one of my visits here about a year before, saying, when are you going to do that study? I want to see that study because it's got to be positive. And so, but it isn't. And so it's not just a question of criticizing the study at all. I think the studies are well done. It's trying to understand it. And in my attempts to understand it, I think the data on the amount of scar tissue, the amount of fixed defect, the extent of LV dysfunction, to me seems fairly logical. There's got to be a time when viability, whether it's there or not, it's not going to make any difference because other factors are going to dominate the prognosis.
Well, this is actually a good quote also. This has generated lots of good discussion. Now, suppose the Stitch trial had shown that viability somehow was interacting with a better outcome. Would that have been interesting? It would have just kind of been a self-fulfilling prophecy of some sort. So this now leads to all kinds of interest. Okay, so what is going on? And Eric is still riding with Stitch, and we look forward to subsequent analyses as well as the long-term follow-up data. There's going to be lots of interesting stuff coming out of this trial, some of which is totally embargoed right now and can't be discussed. But what we do know is I guess the subject at hand, and those two quotes are quite good. Now, first of all, I agree with Bernard. The data in Stitch only pertain to those patients. Okay, if you were not ineligible for Stitch, have a higher ejection fraction, we don't know. There could be something really important there. The ischemia trial is going to be those patients, not these patients. Ischemia is not patients with ejection fractions less than 35%. The Hakimovich data were all patients with much higher ejection fractions. No one had. This is a heart failure population. So there could be a lot of other things which are driving outcomes in these patients, viability being perhaps one of those. But getting back to Eric's question, the real question is, how did I withstand the barrage when this came out? Those of you who work with Kerry Lee know how methodical he is, how careful he is, and when he unveils a set of trial data to you is tantalizing because he takes it one step at a time along the way. And he showed us the overall trial data of Stitch. If you recall, the intention to treat analysis showed trends, but nothing significant in terms of better outcome with CABG versus medical therapy. There were some early crossovers when you adjust for the, or take in that consideration and look at the as treated population, which is done in many interventional trials, significant outcome with CABG. And so I was watching these data thinking, great, I can't wait to see now the viability analysis, because that's going to tell us now which patients actually do better or not. And it's exactly how we did the trial. That the trial was designed by essentially three groups of people. The interventionalists and the surgeons saying we're going to revascularize everybody, as I showed on that earlier slide. The heart failure people saying, no, we've got great drugs right now. We're going to treat these patients medically. And there was actually lots of discussion about that. That also led into why it was difficult to enroll patients in this trial. There were so many preconceived ideas that so many people knew exactly how they should treat the patients. And so enrollment was an issue. And then, of course, the non-invasive guys say, okay, we've got the key. It's going to be the viability test. And, of course, you saw the data. The viability testing showed no interaction with the treatment assignment and the outcome. And so that's what we have. Now, the other thing which Bernard pointed out was, okay, not everybody in Stitch had a viability test. There may have been some baseline differences there. We did look at that. If anything, the patients who got the viability test were sicker. They had worse ventricular function and worse heart failure symptoms. And so agree entirely, if you've got angina, there's a signal there that there's some ischemia and there's probably a viable myocardium. And we also don't know who never got into the trial because they had a viability test first. And that convinced somebody that either there was too much viability or not enough viability, there was no way they were going to randomize their patient. We can't control for that. All we have are the data that we have. But we actually, I think, have good data. We know who the patients are. And although it has led to lots of debate among the imaging community as to why the results came out the way they did. We've sliced it and diced it many different ways, looking at different definitions for viability. We've done that continuous model that Leland Shea has done, and coming up essentially with the same conclusion. So I think in this subset of patients where the ventricular function is so severe, as Bernard said, there's probably many other things which are driving outcome. And in fact, although it's not significant, and I have to say this carefully with Kerry and Leland in the room, because there's no p-value here, it does appear that the patients who are doing the best with surgery were the sickest patients with non-viable myocardium, the biggest ventricles, probably because those patients are the ones who are just critically sick, if you will, where they're not going to tolerate the next ischemic episode. And revascularizing those patients may actually lead to, at least relatively speaking, a better outcome. But that's still, I think, up for grabs.
Dr. Wagner.
Yeah, you make the point that not all, quote, non-viable myocardium gets better with revascularization, and you divide it into ischemic and hibernating. And we've heard about hibernating myocardium for a long time, and I'd be interested in each of your concepts as to what really is the pathophysiology of this hibernating but not ischemic myocardium.
You go first.
It's really shown in this slide, I think. I think of hibernation and stunning as, to some extent, there's similarities, but there are some differences. Stunning being an adverse effect of ischemic injury with no histopathologic abnormalities. Hibernation, presumably protective adaptation to reduced flow or ischemia, which maintains viability. So it may be that hibernating myocardium at rest is not ischemic. And I think the two can be, I think one of the reasons that ventricular function is maintained is by reducing the blood flow so as to eliminate ischemia. Where I think it gets complex is whether, in fact, repetitive stunning with a severely reduced coronary flow reserve, whether repetitive stunning is part of the mechanism of hibernation. And the other component of that, which is, I think, really interesting, is that with time, I think Beanland's up in Ottawa Heart has shown, with time, hibernating myocardium may become necrotic myocardium, and this may be part of the mechanism. So I think you can hibernate without being ischemic, although it's difficult for me to think that these patients wouldn't become ischemic with exertion.
So we've been total gentlemen up here up till now, and when Bernard started to show this slide, I said, okay, now we can put on the boxing gloves, because I was going to disagree until you showed the next part of your slide. Because I think the data now, I mean,
Think I'm stupid?
No. My distinguished colleague, Bernard. The problem we had with stunning was initially it was a good experimental model waiting for a clinical example.
Yeah.
And then we finally got the clinical example because we could open occluded arteries. Hibernation was just the opposite. We had these clinical examples without a good animal model. And we're still searching for a good animal model. So the purists on the basic laboratory side will say, without a model here to prove this actually happens, I'm not sure we know what's going on here. Well, now there's a good animal model. It comes from John Canty and colleagues at the University of Buffalo. Others are doing this as well, where he's creating a fixed stenosis and causing repetitive ischemia. And so my concept of the world now is what Bernard showed at the end here. Hibernation, and of course they can coexist, but it's repetitive stunning. That if you cause enough ischemia over and over again in a myocardial segment, you begin to cause some genetic changes which leads to disassembly of contractile elements. The flow goes down, not in a protective way, the flow goes down because the function's gone down. The coronary blood flow reserve is programmed to what the myocardium is asking us to do. It's a very tightly regulated system, and if the function goes down, the flow goes down. And it's going down because there's this repetitive ischemia leading ultimately to resting dysfunction because of disassembly of contractile elements. That's been shown with biopsy specimens in humans as well as animals. And then presumably with revascularization in some patients, so you reprogram genetically that piece of myocardium and it begins to reassemble and contract again.
I think what's important also, and I'm not sure you weren't part of the editorial, but there was an editorial from Fran Clockie, and coronary blood flow is reduced. That's for sure. And that was debated at one stage a little bit, but it's reduced. And
Dr. Roman.
So it's amazing to have both of you here at the same time, even debating this topic. So I want to thank all of you for actually being here. As you were presenting this data, it just struck me as a fascinating expose of how little we know sometimes, and how much we think we know on another level. So I'm going to ask you a slightly tangential question. So we have this great pathophysiological assessment of what we think is going on, and what the data shows us is maybe a little bit different. In the practice of medicine, we have now things like appropriateness criteria. So I want you to wear the hat, both of you, and say, knowing how little we know after how much we've done, how appropriate is it for us to think about appropriateness criteria in the setting of clinical medicine?
Can we ask Pam to address that?
Well, I don't know, said Manish Patel, but there's nothing more boring than appropriateness criteria. I mean, you've got that long list of things, long list of things where it's appropriate. It's like the new buzzword, it's like shared decision making. You sit down and you show a patient a smiling face and I mean, isn't this what doctors do? You sit down and hopefully you have enough time to go over things with a patient. I think the appropriateness criteria is to try and put a label on what we think is reasonable to do. What clearly we know and we haven't tackled very well is how much inappropriate stuff is going on outside there. Inappropriate revascularization for stable angina, lots. And I think it's our attempt to try and quantify what we think is reasonable and perhaps identify what is unreasonable. But in this area, I don't know, would we do a trial? Could we do a trial?
So I actually should know this as what the appropriateness criteria say. I mean, Pam, I apologize because I actually have a slide of that somewhere in my repertoire as to what the appropriateness criteria say for someone with a very low ejection fraction, whether it's appropriate testing. And I think it's considered appropriate if it will change care. Now, in the heart failure guidelines, I think they got it right, because the heart failure guidelines circa 2013 say that if the ejection fraction is greater than 35, it's a reasonable kind of thing to do. But if the ejection fraction is less than 35, it's more driven by the coronary anatomy and the ventricular function, and not so much myocardial viability. So what I struggle with are the individual patients. It's just like you said, Magnus, so if you got a patient in front of you, it's always appropriate to have the discussion with a patient, and sometimes it's going to be appropriate to get further information beyond the symptoms and the function, because as Bernard said, you have complicated patients these days with prior revascularization, comorbidities, poor distal targets, and patients got symptoms. So what do? You can't revascularize everybody because not everybody's got good distal targets. And so sometimes additional testing may be helpful in individual patients, but I don't know how to show that from a clinical trial perspective, that this is black and white, that we need to do this in everybody.
You know, something else that's, I think, really going to complicate the field, or is already, is what are the causes of late death? So Raj Gulati, one of our interventionists, recently published in Circulation just about a month or two ago, 3 decades of PCI at the Mayo Clinic and looking at 5-year mortality. And what has happened is 5-year mortality now is dominated by non-cardiovascular death. So, how do we factor all of that in at a time when we're not even sure what to do with people who we think will die of cardiac death? And this is where I think maybe viability testing is important, and that is in the patient that is not a good surgical candidate, where there are a lot of comorbidities. I think we just need more information in some of those patients prior to making the very big decision to send them to surgery or other forms of revascularization.
Dr. O'Connor.
Bernie and Bob, thanks for being here. One of the great things about Bernie's debate is that if you go to the winter meetings, he debates himself on this topic, and he wins, unlike today. But speaking of the mode of death, Eric and his team published the mode of death data from Stitch, and it really didn't show a different signal on sudden death versus pump failure death. And the question is, do we know what serial changes in viability, ischemia, and function mean to prognosis and mode of death in the Stitch trial? Do we have follow-up scans, and can we look at change in viability, ischemia, and function as it relates to prognosis?
So Eric has begun to look at that, and I'm going to, I know he can't discuss it right now, begun to look at some of these serial changes, because we have data in patients after surgery, the ones who survived, obviously, to come back for subsequent testing. So we're going to be still dealing with a subset analysis of those who are alive, maybe taking out the highest risk patients, because they're the ones who died. And so we will have those data. And Eric, I'm going to leave it at that point and see if you want to add anything to that.
No, I expect that would probably be embargoed stuff you were mentioning. I do think it's important to kind of probably not discuss it at this point, but there's some, Stitch is very rich in the amount of data that we have available to start addressing questions and asking new things. And I think the functional recovery information, which we've started addressing with Lynn, Carrie, and Bob, and Julio, and others, is going to be, I think, very intriguing and also an opportunity for us to continue to learn from this data set.
Eric, I don't know what you felt at the time of the presentation, but I was on the panel of late-breaking clinical trials, and I was just saying to Carrie, I said I think that this is a modestly positive study. And the chairman of that said, well, how can you say that when they didn't reach the primary endpoint, or the primary endpoint wasn't different? But I still think it was, and I think that there are times when treatment received is relevant. And there was a lot of crossover both in both arms. So I still think of this as a trial that showed a modest benefit for surgery in a very sick group of patients.
Yeah, I mean,
I think the editorial didn't get it.
First of all, I want to thank Bernie, because I couldn't have been more nervous when I was presenting in front of whatever, 10,000 people in that room, and your remarks to start really emboldened me, and I think you were very supportive. And I don't know who was the person. It was a PCI guy. I can't remember who said, "Oh, it's not positive." But I do think of this as a positive study. I think more and more as we look at these data, it is I think we tested a hypothesis that would show surgery to be 25% better than medical therapy. The only thing that I'm aware of that ever has that effect size that has been shown is aspirin, from what I can tell. And so what we showed was a 16% relative reduction. And when you looked at the adjusted as well as the per protocol and the as treated analyses, everything consistently was in support of bypass surgery. So more and more, I think we don't have enough endpoints accrued or enough follow-up. And I'm looking forward to the extension study results to kind of wrap this up a little bit in terms of my perspective. I just want to make one comment. First of all, thank you guys. This has been phenomenal. It's late in the hour. But I started thinking about revascularization and viability when I was an intern, because Chris didn't know what to do with me and Rob didn't know what to do with me, so they kind of put me on this topic of coronary disease and heart failure, which no one else wanted to tackle. Thanks, Chris. And because Galen made Bimal and I work on the Sylvester QRS score and its impact on and trying to understand the effect of the QRS score on revascularization. And that really was the beginning. So for the fellows out there and the medical students, sometimes it does lead to other things. And I think the opportunity to work within an environment like this with people in this room who help move these trials along is so unusual. And I think such a great opportunity for the young folks in here. And I want to thank the people in here who really helped make that happen. Galen, a call out to you from 20 years ago.
My little only comment that Bernie, it was a thrill to me to hear you mention Q-waves. maybe the amount of QRS change could possibly be quantified, and maybe it could enter into the multivariate, I mean not the multivariate, but into the multimodal imaging approach to things in deciding what's really not viable and what is for some reason.
Paul Armstrong's got some great data on Q waves and the results of reperfusion therapy. And it's probably an even better predictor than the time to reperfusion. So it's still alive and well, Q-Waves.
Just one more question, Dr. Kim.
This is a question getting back to sort of the images again. I visited a JO at the Mayo Clinic and I looked at their echoes and they're unbelievable. The echoes are just truly outstanding compared to other places. And I keep thinking that, perhaps there's a danger in getting insights or making conclusions when we say things like, well, based on this data, this is what viability means. Or based on this data, this is what ischemia means, or recovery of wall motion, this is what this means. When, the sort of like the subgroup analysis that I'd love to see is, how reproducible is any of this stuff? If you take those images and reread them again, how often are they called viable the second time? How often do you say that the wall motion improved by that amount, the second time? So I'm curious, perhaps there would have been a signal or there would have been a difference in the signal if you only took the images in which they were clearly reproducibly read.
Well, that's a good question because, at least the nuclear data are digital and we can use a quantitative signal there. In fact, we actually have those data, Ray, because we got the site read versus the core lab read. And there's lots of, what's the ejection fraction? Which test did you use? We have 3 different tests in some patients, MRI, echo, and nuclear. That's not the same number.
No, this comes up all the time. I mean, this is the home of scud heft. But so the guidelines are, the ejection fraction less than 35%. And the guidelines also state that if it's non-ischemic and less than 30%. And even with the Mayo Echo Lab, the biggest echo lab probably in the world, they can't tell the difference between 30 and 35%. And if I want to put an ICD in a patient, and I see it, I don't want to put in an ICD, and I see it comes back 33%, say, well, wait a minute, Jay, what about 38, 39? Or if I do want to put it in, I drop it down by 2%. And in fact, if we then used MRI for ejection fraction, our trials were not based on that. So I think there are times when you have to just know what you don't know. I mean, the limitations of what you know, and not try and kid oneself.
Thank you very much to you both. Thank you to everyone for participating.
That's great. Good job. When are you going back? Tonight?
We're going to Spain.
Oh, you're going to Spain. Great.
To Seville.
Terrific. Good time of year to be there.
Thank you. It's really, really good. Pleasure.